What are the challenges of being an African-American physician in Montgomery County? Find out more right now. My guest this evening is Dr. Tuesday Cook, a noted bariatric surgeon here in Montgomery County. In addition, Dr. Cook is very active with the Maryland State Medical Society, dealing with the minority challenges of practicing medicine in the state of Maryland, including, of course, Montgomery County. Dr. Cook, welcome to Housecall.
Thank you so much for having me, Dr. Doman.
My pleasure. So, since we know each other for years, we'll go on to a first name basis. Tuesday, tell our viewers about your professional background and your current private practice.
So currently, I am a fellowship trained, minimally invasive foregut and bariatric surgeon. I went to medical school at Howard University College of Medicine in Washington, D.C., and subsequently stayed to do general surgery residency as chief resident at Howard University Hospital. Subsequent to that, I did a advanced laparoscopic, minimally invasive, and bariatric surgery fellowship at Penn State in Hershey, Pennsylvania. I practiced in both employed and private practice in Montgomery County for years, more than a decade, and I also now practice in Prince George's County to help fulfill a mission of providing care in places that do not have access to minimally invasive surgery and bariatric surgery.
And very briefly, explain to our viewers who may not know, what exactly is bariatric surgery?
Bariatric or metabolic surgery is weight loss surgery. It is known to decrease the amount of adiposity that a patient has and change their metabolic makeup. And so in doing this surgery of rerouting the anatomy, it helps to resolve things like hypertension, diabetes, high cholesterol, obstructive sleep apnea, osteoarthritis, and many other illnesses, as well as decrease the chance of the presentation of cancers.
Fascinating, and an important contribution to healthcare. So an obvious question is, there are different medical schools around the country, I think around 120. Why did you decide to go to Howard University? Is there any particular reason?
I think there are several reasons. One main reason was that for my life, my mission was to help people of color in terms of healthcare. It was very important to me, even growing up, knowing that I wanted to be a physician, to not only see people like me, my pediatrician was a Black man, but also to know that I could somehow contribute to improving my society and my community. You know, I knew that from medical school as well as for residency that I would be, I was confident in the training that I would get. I was trained by people who were the first Black colorectal surgeon, the first Black head of the American Cancer Society, Dr. Lasalle Fall, one of the first Black transplant surgeons, Dr. Clive Callender. And so I felt very confident that I would be well trained by people who looked like me and had no other intentions. You know, it really took the guesswork out of people's intentions, you know, in a surgery residency, which can be challenging when you are told to read something or present something for M&M and prepare. There was no question that they just wanted me to be the best physician I could be, especially to be able to take care of my community. I will tell you, funny enough, that when I was interviewing, even for my fellowship trail, I was only one of only 3 Black women on that entire fellowship trail. And so that really stood out to me, having been Howard for some time, that everybody wasn't just a Black physician, that, you know, there were very few of us. But those were some of the reasons that I chose to attend those institutions.
Fascinating. For our viewers who don't know, M&M stands for Morbidity and Mortality, a common teaching conference held in university hospitals. So what was it like when you were at Howard in terms of not only mastering our craft of medicine, but did social issues come up frequently during lectures or just as part of the daily dialogue?
Yeah, actually, I think that was a big part of training. It was not only to learn medicine, the art and science of it, which in and of itself can be compelling and challenging, but also to learn the person, the patient as a person, to be able to manage someone who has difficulty coming to visits because of childcare or transportation, and not to just label them as non-compliant, but rather to reach out and work a little bit harder to ensure that patient gets the same treatment as someone who may be of a higher socioeconomic status or have a different mode of employment, to really see that person as someone to whom you have to provide care, and you may need to go about different routes to do so.
Did you find that within the community, there was a lot of distrust when it came to, for example, government recommendations for vaccinations, given the infamous Tuskegee syphilis experiment?
So I don't know that there was much mistrust when I was training. Remember, I trained at a predominantly Black institution. And so the patients, when they came in there and they saw people that looked like them, people from similar backgrounds, sometimes same socioeconomic status, and sometimes not at all, because there's quite a range of socioeconomic status amongst Black people and other people of color. Um, I think that they felt comfortable that they would receive the appropriate care and the appropriate information, as opposed to going to some predominantly white institutions where they may have some mistrust because of knowing of things, not only of Tuskegee experiment, but Henrietta Lacks, who
Right.
had her cells taken and was unable to, no one recognized that. And they renounced these cells that, would not die, at the date of her death, or, experiments that were done in order to create the vaginal speculum.
Right.
Um, and so I think that there was not much mistrust where I was. And I think that that's one of the reasons that we definitely should have, patient-physician concordance. If we can, we should have implicit bias training for physicians. Cultural competence is a big thing that we should have in order to have patients have more trust in health professionals in general.
Yes. Sure. Uh, I believe in the USA currently, there's about 900,000 physicians, plus or minus. What is the latest data on the African American community physician population?
Well, sad to say, it's pretty abysmal. There has been only about a 4% increase in Black physicians um, in the past 120 years. And so that's quite disturbing news to hear. Black physicians make up only about 5% of doctors in the United States. That's really low. Women in general make up 36% of physicians in practice in the United States, and Black women make up 2 to 3% of all physicians in the United States. African American males or Black men they went from 3.1% to approximately 2.9% over 40 years, and there are fewer Black men that entered medical school in 2014 than in 1978. And so the numbers are so low that we need more, not only allyship and mentorship, but we really need sponsorship, where we put people of color and Black people in positions to help them not only enter medical school, but to stay in medical school and get into the appropriate residencies and fellowship.
The data I understand for undergraduate work, universities, colleges, is that there are more African American women than African American men. So is that translated to medical school, where there's more women going to become physicians?
It does translate. Funny enough, the largest growth of groups in medical school has been Asian people of Asian descent, and that's Asian woman. That has been the
Yes.
highest growth of group in to attend medical school. But like I said, there really has not been an increase in physicians. Like, it's only 4% in 120 years. That's a sad number,
Yes,
because it
it
doesn't
is.
it doesn't reflect the population growth.
No, it does not. It does not. So, what are the benefits you think, besides trust and a commonality, for an African American patient to be cared for by a African American physician?
Well, I think the data is very clear that patient-physician concordance leads to better outcomes. We saw that study that came out regarding newborns and morbidity and mortality when they had a Black pediatrician or NICU doctor. We know that it's, even with cultural competency, we find that there are better outcomes and better patient-physician satisfaction scores when there is concordance. Um, this has, of course, there's never enough of people of color to address the number of patients of color. And so it really, lends itself to saying this is why we must have implicit bias training, not in the state, not only in Montgomery County, but throughout Maryland. This is why we must have cultural competency in order to have enough physicians be able to take care of patients and engender their trust and get good healthcare outcomes. It leads to better compliance, and it leads to people understanding when patients are not really being non-compliant as opposed to needing a different tact.
Are there any programs nationally and in particular statewide in Maryland whose mission is to promote African American members of the community to seek a career in medical school, medicine?
Well, there's some national organizations. There are some in Maryland as well. In Maryland, you have the Office of Minority Health, and it's not completely geared towards pushing Black people in medicine, but it definitely, if you go and you review the information, it definitely lends itself to giving information that will highlight the fact that we need more people. There's a National Medical Association, which was created because they wouldn't let Black people into the AMA. And
Right.
so there are many programs, mentorship programs, sponsorship programs to highlight Black students and get them from college to medical school to residency. And I implore people to actually go and support that organization as well, because it really does help, and it's a national organization. And then there are smaller ones. American College of Surgeons even has mentorship opportunities for students to delve into, to seek that. I am also on several committees for the American Society for Metabolic and Bariatric Surgery, and we have a diversity and inclusion committee that is working towards a mentorship program. I'm also president-elect for Montgomery County Medical Society, and I hope that that can be something on my platform as well. So I think that there are organizations that exist. We absolutely need more. It can't just depend on, historically Black colleges and universities. There aren't enough, and, some are closing. It has to really exist in every institution in the United States and in Maryland, so that we have enough to address the deficit of and the paucity of Black physicians here in the state and in the United States.
Share with our viewers some of the double standard African American physicians have run into, for example, in Maryland, things that would never occur to a white physician. What kind of stories have you heard or experienced personally?
Yeah, well, it's funny you say heard and experienced, because I was at Howard, I would not experience some of those things, but I would hear some of my colleagues and friends that had gone to predominantly white institutions experience things that weren't the greatest. And I will say from my own personal experience, when I rotated to a hospital in Northern Virginia, I was called into the department head's office and told that people were nervous to work around me, and that even though I came in at 4 a.m., and I saw all the patients and I was ready for the operating room, and I apparently was stellar in the operating room because I got recommendation letters from the attendings there, that they thought that I should smile more to make people feel more comfortable. And I was highly offended by that, because I knew that had I been a white male, my assertiveness would be viewed as that, as opposed to being seen as someone who's angry or unapproachable. The patients surely loved me. The evaluations I got, were great. And so it was a little offensive. I recently read an article that was in, I want to say it was in JAMA, and it was a young white male who said that he thought about how it was to experience medical school, medical training as a physician, as opposed to being a Black physician. And he said, he wondered what it was, knowing that racism is a system of, structuring opportunity and assigning value based on appearance and that unfairly disadvantages some individuals. And he said, he's been taught from an early age that people of his own race can become doctors. Throughout his education, he could succeed academically without people questioning whether his accomplishments were attributable to affirmative action or his own abilities. During college and medical school, he never struggled to find professors or role models who were academic and, who looked like him. When he applied to medical school, he could choose from any elite institutions that were founded to train inexperienced doctors of his race by practicing medicine on urban or poor people of color. He was reminded daily that his medical knowledge was based on discoveries made by people who looked like him, without being reminded that some of the most painful discoveries were made through inhumane and non-consensual experimentation on people of color. If he walked into an exam room, they automatically assumed that he was a physician. I have had many times people assume that I'm someone else other than who I am. I've actually been asked why I'm sitting at the nursing station, or asked to pass a bedpan, which I happily do. And then once, I've helped the patient and they say, well, I'm waiting for the surgeon. I said, well, here I am. And some people are, a little perturbed by, their behavior beforehand. But, very often it's not assumed that I'm the physician in the room if I'm at a PWI as opposed to a predominantly Black institution. The young man also said that if he forgot his ID badge, he could walk into the hospital and know that he wouldn't be stopped by security, or followed by security. He could respond to a call for medical assistance on an airplane, and they would just assume that he is a physician. And so he really went through in his article. I thought it was very meaningful, the advantages he had just based on his race. In his training from undergrad all the way up to residency, and it really highlighted and spotlighted the differences and the microaggressions that we as people of color do experience daily, and that those microaggressions really can have a negative outcome on not only our health, but our mental health, our physical health, our mental health, and the way we view things, and it can be tiring.
I bet. We're going to continue this fascinating interview with Dr. Tuesday Cook about the challenges of being an African-American physician in Montgomery County. First, we're going to pause for a brief public service announcement. Don't go away. We'll be right back.
Before we celebrate the freedom most Americans have, we must fight for the freedom all Americans deserve. Because all lives can't matter until Black lives matter.
We're back. My guest this evening is Dr. Tuesday Cook, a noted bariatric surgeon here in Montgomery County. She's also active with the Maryland State Medical Society in terms of committees that deal with racial diversity in the medical community. Tuesday, when we paused for the break, we were discussing the challenges of an African-American physician in the medical community. Let's now look at the other side of the coin. What kind of stories have you heard from your patients about racism in the medical community?
Well, I've heard many, and I want to point out that we live in metropolitan DC, being right outside of the capital of the United States, and yet still, there are still wide and varied treatments being offered to patients of different color for the same diagnosis or the same stage. There's still a lack of access to care for patients who live, just a few minutes outside of the city. And if you think about it, even in Montgomery County, there are pockets of patients who don't have access to the hospital like others. And it's just in the single county. I'll give you an example, even Prince George's County, where I also am operating with Adventist Healthcare as the director of the MIS and Bariatric Surgery program. In that county, there is the highest rate of obesity, hypertension, peripheral vascular disease, stroke, and kidney failure, which are at levels that's in some cases higher than the state level, and in some cases higher than the national level. And again, this is in 2022 in a metropolitan area. And so patients do experience implicit bias, and patients do experience, some poor events when they go in to see, perhaps people who are providing healthcare who don't quite understand where they're coming from. But we also need to get them there. And so there are so many aspects to the need for improving treatment that I think it's a multifaceted problem that needs to be addressed circumferentially.
Sure. So of course, this comes down to leadership in the medical community, as well as leadership in our government. So what is your sense about the lack of racial diversity in the medical community? For example, the Maryland State Medical Society.
Well, with the the Maryland State, with MedChi.
MedChi, yes.
Well, I think that we're doing a better job of increasing the number of people of color involved. There have been people there, like Dr. Willada Edwards, who's been there for years,
Yeah.
and championing the issues that need to be addressed for Black people and people of color. And with the IDEA task force, I think that we've gotten even more people involved who can now have a voice and a seat at the table in improving the health of people in Maryland and in all the different counties of Maryland. We have representation from all sorts there, and I think that this task force really is the start of a really great and big thing in terms of trying to improve healthcare. I think that really there's a lack of diversity, a lack of racial diversity in leadership in academic positions. Not even just in the medical society, but really in academic positions across the United States. The first chairs of an academic surgical department happened in 2021 with Dr. K. Marie King and Dr. Hayes Jordan at Howard. Dr. K. Marie King is a hepatobiliary surgeon. Dr. Hayes Jordan is the first Black pediatric cancer surgeon, and she actually created a method of doing chemotherapy for pediatric patients. And in 2021 is when we got these first academic chairs of surgical department. And to bring a sense of perspective to this, there were multiple Black women in space since the 1990s. Mae Jemison, Joan Higginbotham, before there was a Black woman chair of an academic surgical department. This is almost 150 years after the idea of the position. And so, even the first Black woman who was the head of the American College of Surgeons, Dr. Patricia Turner, she became that. She's the youngest. She's the first former division director. And this, again, is 109 years after the inception of the American College of Surgeons. So, there's a lot of work still to be done just on a national level, an academic level.
So within the community, is there a sense of discouragement that very well qualified candidates are not treated with the same degree of respect as other candidates when they're applying for an academic position?
Oh, absolutely. I think that definitely exists. It's I'll give you an example. In Annals of Surgery in 2020, there was a retrospective review of the AAMC 2017 faculty roster, and it was to determine the medical school surgery faculty academic rank, tenure status, and the department chair roles, and the number of NIH grants awarded from 1998 to 2017. And for the U.S. medical school surgical faculty, there were 15,000, a little bit more, 15,600 people. There were 123, that is 0.79% of Black or African American women, less than 1%. There were 11, that's 0.54% tenured faculty, and there were 73 assistant professors, 10 full professors. Now, there was 11 last year because my really good friend, Dr. Lori Wilson, who lives in Potomac, became a tenured professor in 2021. She's a surgical oncologist. And so 11 full professors in surgery in the United States, 372 U.S. department chairs of surgery. None were Black until the two that I mentioned in 2021. And NIH grants awarded to academic surgeons, there were 9,139 academic grants. Only 31.34% of those were awarded to fewer than 12 Black women. 12. And so again, those numbers, they speak volumes when it comes to increasing rank, being offered and placed in and earning, which they have, leadership roles, both in academia, and those things matter. When you work as hard as the next person, and sometimes a lot harder, and have more publications and still don't receive the recognition and the things that go along with it, like placement in those positions, it can be quite disheartening.
Of course, of course. Now, I know in the past when you've written and talked about this very important issue, you used the term microaggressions. What does that exactly refer to?
So microaggressions is also referred to as like death by a million cuts. That's one way people put it. People of color, it can affect, Black and Indigenous and people of color in many ways. Adversely affect their performance. It can affect their mental health, their actual achievement, self-esteem, their physical health. It can affect their advancement in their career. Discriminated groups in academia are less likely to get salary promotions, leadership positions, awarded grants or publications, like I just discussed, and increase their academic rank. And that can lead. It's a kind of continuous cycle that then decreases the amount of effect we can have on patient healthcare and increasing patients and improving patients' outcome. And it can have an effect on the people who we want to bring up behind us. And so it's important to make sure that institutions have policies against microaggressions, and once they occur, how they deal with them. Those are the only things that are going to improve the environment in which people of color work.
You've also used the term BIPOC, BIPOC. What does that stand for?
That stands for Black and Indigenous People of Color. And so, it's interesting. Very often people will refer to every brown person as African American, but truly there are so many different cultures and ethnicities in the diaspora. For example, I'm actually a Caribbean person, and so a person will come into the hospital and we'll put African American, but really they are from Senegal, or they're from the Caribbean, or they're from Europe, and so I think those things, it helps to know some of the culture and ethnicity, because that might be one way that we can reach the patient that is different to the standard or the usual, which doesn't reach everyone. There should be no usual. There really should be very specific and tailored treatments, just like we do for everything else.
What is the black tax?
The black tax is really the fact that the life expectancy of Black people in the United States is decreased from dealing with all of the effects of the social determinants of health that exist just by being Black in the country. And so, there are higher rates of things like hypertension and high cholesterol and diabetes. Yes, because of social determinants of health, but also because of racist policies that have existed for many years, since the Jim Crow laws. In the 1600s, Black people could not, and Indigenous people actually, could not grow their own food. They could not leave a 1 mile radius without permission. They could not hold jobs that were of their own business. And so, these policies were lawful policies. They existed, and so they've morphed now. But the black tax really refers to the fact that, the life expectancy is much lower because of all of the social determinants of health that affect people of color throughout their lives. We already know that your zip code actually says more about what your health will be like, more than even your genetics. And so those are the things, when you look at the COVID numbers, and COVID really highlighted these inequities. But if you look at the COVID numbers, and they said the decrease in life expectancy, that of Black people went down 3 times as much as anybody else. And so that really speaks volumes. These inequities in health and everything else really always existed, but I think COVID really highlighted the effect of that.
Despite the many, many challenges you covered this evening about African American physicians in our country, there have been a number of distinguished physicians who have contributed to the advance of medicine. Can you share some of those names and what they contributed?
Oh, sure. He's not referred to as a physician, but I'd like to start off with Onesimus. Onesimus actually helped to eradicate smallpox. He came up with the idea of vaccination, and I shouldn't say came up with it, but he actually introduced it to I want to say the person who had him enslaved in Boston. But the idea of vaccination and eradicating a disease by rubbing an open wound on somebody who's infected actually came from him, a person who was enslaved, who, was able to share that knowledge. I know it was actually probably done in the East prior to that, but that's how it really surfaced here. Dr. Charles Drew, who many people know with his pioneering ideas in blood banking. So nobody would be able to get a blood transfusion if it wasn't for Dr. Charles Drew, who was a surgeon. There are numerous.
Before you go on to another distinguished physician,
yes,
could you share with our viewers the story of what happened to Dr. Drew?
Well, Dr. Drew actually, and it's Dr. Lasalle Fall, who was my attending physician, world-renowned surgeon. He's a surgical oncologist. He actually would every year give us the story of Dr. Charles Drew, who died en route to the hospital after a car accident. And he very much would make sure that we understood that he didn't die because he didn't get treatment that was adequate. He actually died en route, but he was involved in a car accident with some other notable physicians and colleagues, and it wasn't actually for him a lack of treatment secondary to his color, but that absolutely does exist. Even again in 2021, we have Black female physicians who have died in childbirth, and already that and I digress because there's so much rich information to give for people to really understand what we deal with, even with physicians as patients. There were multiple physicians who passed away trying to advocate for themselves, if not from COVID-19 but from pulmonary embolism and DVTs. Black people's pain isn't treated the same. There was a study in 2016 which evaluated medical students who thought that Black people didn't feel the same pain as other people. And so this was a very popular idea and existed from the days of J. Marion Sims, who would operate on enslaved patients without any anesthesia because he didn't think they needed it. It's a known fact. There's data that has been put out that the babies of Black women with college degrees still have a higher morbidity, as does the mother, and mortality than the babies of white women with only a high school degree. And so we know that these inequities still exist and are current today. The AMA had a podcast that had two men speaking that said that racism wasn't real, and that it was it was a fallacy. They have since pulled down that podcast, but that happened in 2021. And so this is not just historical data, but it's things that are ongoing and that help to contribute to the continued, poor social determinants of health that affect people of color, and the continued lack of access to equal care.
The Charles Drew story I heard when I went to med school, when they explained he developed the technology for the blood bank, was he was in a car accident. I think it was in South Carolina, and an ambulance picked him up as well as the other victims. And the first hospital they went to, the closest, they pulled up and he was denied entry because of racism. And they explained he needed a stat blood transfusion. Yeah. And he was denied the very technology that he had invented. And then, of course, he had died en route to the second hospital.
So, Dr. LaFall, he would always want to clarify that for us. And he actually, he knew him, he trained with him. Of course. And he actually would always clarify that detail for us. Not that it didn't exist, but that, that it wasn't quite that story.
Okay, well, that's what I heard.
But and that's not to say that it is not highlighted in many, many other aspects. There are people who come to see me now who have been not treated in a way that they would have preferred to be treated in other institutions or by other physicians, and it's sad. And sometimes I'll call sometimes I'll call up the physician and say, this is how the patient felt, so at least they can get some feedback. Because sometimes, implicit bias is called that for a reason. Sometimes people don't recognize it. Very often, our actions are guided by things that we don't recognize. Sometimes I recognize it and it's purposeful, but sometimes feedback, I think, is helpful, and that's why we're working now, towards getting a grant to support implicit bias training for all physicians in Maryland.
Well,
I will also tell you that a recent survey was done that said that physicians in Maryland that were Black got lower pay compared to those of other ethnicities and races.
terrible.
Yeah.
So we have 1 minute left. If our viewers have any questions, how can they get more background information and reach you?
I'd love to hear from any viewers that have questions. They can go to the Adventist Healthcare website and they can look me up there. I am listed as the Director of Minimally Invasive Foregut and Bariatric Surgery at Adventist Healthcare for Washington Medical Center. And I welcome any calls right to the number that's also on that website.
Well, thank you for joining us this evening on Housecall.
Thank you for having me. It's been a pleasure.
My thanks to Dr. Tuesday Cook for a very informative interview. Quite frankly, Tuesday, I think we could have chatted for another hour. We have so much to cover. I, by the way, should point out that every year we have traditionally a newly elected president of the Montgomery County Medical Society as a guest to cover healthcare issues in general. So I look forward to another visit together real soon.
I look forward to it as well.
My thanks to my team at the station that makes this program possible. And finally, my thanks to the viewer. Thank you for letting us into your home. Tell us how we're doing. Make any suggestions to my practice website, montgomerygastro.com. As for our next show, it's going to be a fascinating program. Dr. Thomas Fishbein, director of the MedStar Georgetown Transplant Center, will be providing an update on transplant technology. It's going to be an important show. See you then next time for another edition of Housecall. Good evening.